Good morning. So I have the pleasure of doing the first talk where everybody is still trying to wake up, and we've dimmed the lights nicely to help with you waking up so that hopefully you can see the screen better. All right, so when talking about palpitations, I'm hoping to give you guys an overview of the things that I find to be important in the history, identify things that would really be concerning in a physical exam, as well as a concept of when we should be doing and what sort of diagnostic workup is appropriate. Hopefully we can give you some comfort in patients that have a very reassuring history and exam and evaluation, to be able to keep those patients in your practice, but then also to give you a better idea of really who should definitely be referred versus maybe patients who don't need to be referred. And then we'll try to go over a few EKGs, and then if we have time at the end, I have a couple extra EKGs that I find quite interesting, but we'll try to go over some basic EKG things that are really important for the evaluation of palpitations. Now, we're going to focus on palpitations, but when I think of palpitations, I'm immediately thinking about chest pain, and I'm also thinking about syncope. In fact, when I pre-chart for these patients, my pre-chart is for chest pain, palpitation, syncope. So that kind of really lets you know immediately what I'm thinking as a pediatric cardiologist. I don't know what history I'm going to take when I hear that patient coming in with palpitations. So these are often intertwined. We're going to focus mostly on palpitations, but this is the way that I'm thinking before I've gotten even that first thing when I just hear palpitations or that's something in the complaint. I also think about that when I hear chest pain and syncope for the history. I don't know where I'm going with this just yet. So we're going to follow the case of this patient that I had who was a 16-year-old male who came in with the chief complaint of palpitations. So first, what is palpitations? So really, it could be defined as a rapid or irregular heartbeat, but really anything that you're feeling that potentially feels unusual to you. So it really comes down to patient perception, which means that many times they're going to feel palpitations that are completely harmless. And we've got to figure out whether or not their perception is warranting additional evaluation or not. Now, a lot of times a patient will tell you what is their most significant symptom, which is why I kind of had that first slide first. They may tell you, I really don't feel like I can breathe very well. Or maybe they're going to tell you, my chest hurts, or I feel lightheaded. They often will start with their most distressing symptom, and it might not be really where we want to focus. So we want to definitely get a good sense of what's going on, and when we're taking these histories, be able to pivot appropriately. The first things that I want to know when somebody's asking me or telling me that they have palpitations is, I really like to get the big picture, really simple facts. When did something start? When did this really start? How long ago? And then how often? Are there any other kind of things that they may be describing? Are we talking about one thing or potentially multiple different types of palpitations? And then I start to try to dive into some of the details about them. And these are still kind of very surface level, concrete level details. How long do they last? And then we start to get into some of the more subjective things, like what do they feel like? When I ask patients to describe their palpitations, I usually let that, what does it feel like to you? And then I let that sit, because sometimes the kids really need a lot of time to think about that. But if they're struggling, that's when I'll give them some of those additional hints, like, is this a rapid heartbeat, a racing heartbeat? Is this a forceful heartbeat? Is this irregular? Does this feel like it's beating in a funny or unusual fashion? But I usually let the kids try to describe it first, and if they really struggle, then I'll give them those other things. And I find even some of the more verbose teenagers sometimes take 5-10 seconds to try to find the words for it. Then I start asking about the fine details of it, like, how does it start? How does it end? What are you doing before it started, then how did it start, and then I also really focus on how does it end. And some of the key features are, is it sudden or is it gradual? Sometimes you'll get a sudden onset or a sudden resolution, and they'll give you a history of gradual. So they may not be symmetric, but that's a really important finding to me and helps increase or decrease my suspicion. So in our case, we had him saying, this started about 6 to 8 months ago. For him, this was in the early fall when basketball practice started. But he said, it really didn't happen much during basketball. Now he's starting to do pitching. Baseball's kicked up, and he's really having it happen a lot when he pitches. Doesn't really happen during practice. Maybe happened once without a game, but it wasn't really that impressive to him. Typically lasts 3 minutes to 20 minutes, can vary a lot. And he says, it feels like my heart's beating really fast. And he says, like, when I'm pitching, all of a sudden it starts to race, and then when it finally goes away, it just stops. So he's given me some interesting things. It's kind of an unusual pattern here, where pitching seems to be the thing that causes it, but he can do basketball just fine. So I'm kind of starting to think, okay, is this more likely going to be a cardiac thing, less likely to be a cardiac thing? That's what we're trying to figure out. So there's not anything on either one of these that is going to give you a slam dunk, not heart, definitely heart. And I think probably most of the cardiologists in this room would tell you that everybody has given us a history that has forced us to be wrong. So our index of suspicion may be very high or very low, and we found things because the history is not always reliable. So when I take into consideration, I'm always thinking, okay, is this moving things up, moving things down? But it's not necessarily going to be a definite thing because the quality of history may be suspect, and patients' histories often change. So duration tends to be longer and episodic. That's more concerning than something that's very brief. And this is, I'm thinking of things like SVT or VT, the tachyarrhythmias. Shorter, although we could certainly have things like PACs, PVCs that maybe you're feeling those every so often. Those can be short, but also a whole heck of a lot less concerning than some of the paroxysmal tachycardias. Racing, very fast, too fast to count, concerning findings, although sometimes it just depends on how fast you can count and what your perception of fast is. I've had many kids come in and tell me, my heartbeat is way too fast to count. But I have a very unconcerning history. Maybe we're doing testing, maybe we're not. And then they come back and they say, I counted my heart rate, it was 90. Not even fast. But the perception was that it was fast. So that's what I mean by the history, we need to take a little bit with a grain of salt, but this is helping us raise or decrease our suspicion. So he says, again, that his heart is beating really fast. It's a sudden onset and had a sudden resolution. So now we're thinking, okay, what other information is going to be helpful to think, is this cardiac, potentially non-cardiac, other sorts of things? I think about activity a lot with palpitations. If they're having it and they're doing something, how does it impact their ability to continue doing what they were doing? Now, this is another one of those grain of salt because it's going to depend on the patient. So if we're thinking somebody's having SVT, well, a little bit of it's going to be determined by how severe the SVT is, how well they're tolerating it. But older kids may push through it, especially if they're really motivated. Some kids are not going to come out of the game. They may have a broken finger, sprained ankle. They're not coming out. That's the kid that maybe this history not going to be that great. But the younger kids, especially the little ones, the 5-year-olds, they're not going to keep playing if it hurts. They're going to tell you and show you through how they're acting. When that changes, well, that's going to vary from kid to kid, but between 5 and 10, you just have to kind of get to know the patient and see, do I trust how their palpitations affect their activity? In that same sort of thought process, a lot of times we'll get patients sent to us because parents are worried their heart's beating too fast, but the child was playing and was flushed in the face, and they don't like the fact that they're red in the face, and now their heart's beating fast, and now they're making them sit down until they're no longer red in the face. So again, the kid wants to go back out and play. That's a great history. I love that. And they're red in the face. Usually color change I do care about, but I like red in the face. Usually means the heart's working great. Other colors, I'm a little less happy about. Doesn't necessarily mean it's going to be heart, but I don't like blue, green, pale, gray, purple. I'm a little bit more worried. I always ask, did you try to count it when we're talking about how fast it seems? I'd say it's probably a third of the time somebody's tried, maybe even less. So a lot of times it helps to ask that question because you've now informed the family, hey, maybe I should try to check that out. And we can talk about ways to check out the heart rate. Just simply, I can count it or it's too fast to count. That's valuable information. If you have a watch, so many people have got these smart watches now that give you a heart rate, that you can put that on them. I always take devices with a little bit of a grain of salt. My watch, it's $1,100, really good sports watch. It always picks up my cadence, my running cadence, when it's cold out. And in about 5 minutes in, I think my hands warm up, and it finally gets my heart rate. So it might not give us an accurate number, but it gives us something, and we can at least start working with that. So I always take devices with a little bit of a grain of salt, but it could, if we get a heart rate of 220, 240, wow, okay. We're all hopefully paying very much attention to this patient. Additional history, this is things that I want to now figure out, what else could this be if this is not going to be the heart? So these are going to be either things that increase my suspicion for poor tolerance, things like chest pain, lightheadedness, am I pre-syncopal? How is the breathing? Are we having visual changes? Has the patient passed out? Now I'm even more concerned if we're having palpitations and passing out. Nausea, vomiting, these can all kind of help us understand how well somebody may be tolerating potentially an arrhythmia episode. But then other things, we want to kind of round out that differential diagnosis, thinking about the non-cardiac potential pathology that could be out there that may be a reason why somebody's having palpitations. So this guy, he's a star player. We've kind of, I think, established that. He doesn't want to come out of the basketball game, even if he's having palpitations. He's going to go full court. He's not coming out. He doesn't come out for baseball either, but he says it really makes it a lot harder for him to pitch. His coach and his dad say, he looks a little pale. They've appreciated a color change, but it's not so dramatic where they're really worried, but they're concerned. The patient thinks it's probably too fast, but he really hasn't checked. He just really perceives that very fast heart rate. He says it's a little bit harder to breathe, but otherwise doesn't really report any other symptoms. So whatever he's experiencing, he seems to be tolerating it well enough to continue playing sports. So he's probably not, whatever this is, having something that's going to place him at very high risk of something like a sudden cardiac arrest or some other really serious adverse event. So obviously we're going to want to have the past medical history, medication history, family history. Probably a lot of this is known. Now, most commonly we're going to see SVT in kids. That's by far the most common arrhythmia, especially outside of infancy. And while I've seen a few families that have way too many patients with SVT in it, and it can run in families and can be genetic, the grand majority of cases are sporadic. Now, certainly if we have a history of things like cardiomyopathy, sudden cardiac arrests, SIDS in the family, then a lot of these things could increase our suspicion for some sort of inheritable arrhythmia, but that's going to be the minority of our patients who have arrhythmias. So in our case, he really didn't have anything significant. I'm going to go back as well. I don't know if I can go back or not, but I'll just stay on this slide. ADHD medicines I think are worth mentioning. I have seen not a lot of patients who really have a big problem with ADHD medicines, although sometimes I'll get patients who come in with tachycardia and palpitations associated with ADHD medications, but a lot of times it's not going to be a big factor for arrhythmia. If you're getting a very concerning history, it could be reasonable to say, I'm a little worried about this and I'm going to pause the medications. And a pause can be sometimes informative that maybe this is related, but a lot of times it's not. I think I just went backwards. Okay, now we're going forwards. So I've got this big list of things, and this is by no means exhaustive. And again, I think we're thinking this, I'm approaching this from the outpatient perspective. We're not in an acute care setting with somebody who's coming in with active palpitations, with active tachycardia, with active symptoms, but somebody who's coming to you and saying, I've been having this experience. In some cases, those acute care settings are a lot easier to manage because you're gonna go, what rhythm are we in or not? What's our heart rate? What's our vitals? Now becomes a lot easier to evaluate those patients. But for those of us who are now seeing this patient and he's like, yeah, I feel fine right now, these are the things that we're thinking about. And I would break it down into a few broad categories. One is going to be the paroxysmal arrhythmias. So that's going to be your SVT type things, VT. Depending on the history, PACs, PVCs would fit into that. We could have underlying cardiac disease as the other broad group, and then the last group is going to be non-cardiac stuff. Some of the things on here are more likely to cause other things like chest pain or potentially passing out, but they could all be associated with arrhythmias. And a lot of the evaluation that we want to do is to help us evaluate for these sorts of things. Can also break this down into kind of an acute or paroxysmal versus a chronic. I have seen patients come in and present with like just chronic palpitations who had dilated cardiomyopathies. Although you could have acute arrhythmias like an SVT or a VT with cardiomyopathies as well. And then we want to think about all the other sorts of causes, which this is going to be the grand majority of things that are going to cause palpitations in kids. It could be medications. We could have anxiety disorders. We could have thyroid disorders, other sorts of endocrine. Popping back up with the syncope, the vasovagal, orthostatic. I will mention briefly about orthostatic hypotension. It is extremely common for patients to feel a mild increase in their heart rate when they're having those orthostatic symptoms. So if you get that very strong, I stand up, I get lightheaded, I have palpitations. While we would still consider arrhythmia on differential diagnosis, if it's extremely reproducible and otherwise consistent with orthostatic, it's going to be a very low yield diagnosis. Normal physiology. That's probably one of the more common ones that I see. With regards to anxiety, I don't think that is something that I use to increase or decrease my suspicion, because anxiety is often a part of palpitations, and I'm not going to pretend to know that that patient has appropriate anxiety because they're having a feeling of doom, because they're having some sort of really bad life-threatening arrhythmia, or that they're just having an anxiety reaction and they have that same sort of feeling of doom. I don't think I can tell the difference from history. So while I'm certainly thinking and trying to understand how much anxiety is present in this patient, to me, I don't use that to increase or decrease my clinical suspicion. We'll obviously look at the physical exam. Usually, it's going to be normal. However, if we're finding other sorts of abnormalities, then that's going to be quite helpful. One thing that I think is often not necessarily really actively looked for is anemia. I will often look at the hands just to kind of see how pink or pale they are. I have seen a handful of kids that had severe anemia, and that was the cause of their palpitations. But certainly if we're finding significant abnormalities on their exam, loud murmurs, gallop rhythms, rubs, abnormal heart rhythms because of extrasystoles or some other cause, then that's going to greatly increase our suspicion. But most often, my exam on patients with palpitations is completely normal. And in our case, he's got a sinus bradycardia, or a presumed sinus bradycardia with a heart rate of 54. He's an athlete. Otherwise, normal exam. So now we're kind of like, okay, do I need to do anything else at this point? You've done your history, you've done your physical. You can consider lab workup. And your history is going to kind of dictate how aggressively you feel about these or potentially other tests. I think an EKG is warranted. And I think that in the case of palpitations, I think of the EKG as an extension of my physical exam. There are things that are going to be on the EKG that I cannot hear, feel, see. So I think that that's a very low-cost test and warranted. Even if you've had one a year or two ago, it's very reasonable to repeat that. When we're doing EKGs, I think it really helps to start with asking what the clinical question is. Because EKGs, this giant box of lots of things. There's rhythm assessments, there's axis, there's hypertrophy, enlargement, there's all these physiologic things. There's what are the ST segment changes, or what's going on? There's so many things. So I think if we start with just saying, what do I really want to know with this EKG? We can at least demystify it and help you with your clinical assessment by going, I don't think any of these big bad things are here. How could I, maybe I'm still very concerned, but I'm not that worried that I'm missing some monster. So when I think of the EKG for palpitations, I want to know what the rhythm is. That's the first thing. Then I want to know arrhythmia syndromes, and that's where I think about that extension of my physical exam. I can't see WPW, long QT, Brugada, all these other sorts of potentially identifiable arrhythmia syndromes on your physical exam. Maybe I have a hint that that's there from your history, but I can't see that. Cardiomyopathy screen. If there's no murmurs and we're not having a gallop rhythm, we may not have any physical exam findings to suggest cardiomyopathy. So this will help screen for these sorts of things or other really significant structural heart disease problems that can cause palpitations. Now, usually these other things are going to be like severe aortic valve stenosis, pulmonary hypertension. We're probably going to have something that makes us go, this exam is abnormal. But cardiomyopathy may not be. And usually the EKG winds up being normal in this case. So a normal EKG does not rule out that you have WPW. You could still have an accessory pathway, it could just be concealed. Should rule out long QT syndrome, but it's not going to rule out AV nodal reentry tachycardia. It's not going to rule out ventricular tachycardia, unless they're actively having the palpitations that they were describing. So now we get to do some interactive things. I have a few EKGs that we're going to go over. This first EKG, can we see these okay? Do you feel like this is good? We can dim the lights a little further if we need to. Okay. If we need to dim the lights further, we can. So this computer read this as sinus bradycardia with sinus arrhythmia, rate of 52. Pretty much read it as a normal EKG. Now, do we have a pointer, any chance? Or do I just, if not, I can just describe. So if we look over at leads V3 through V5, we'll see that there is some pretty significant ST segment elevation. Some mild changes kind of elsewhere, but otherwise the T waves look relatively normal. Everything is looking overall okay on this. I didn't give you an age, so we don't know like whether or not there's voltage criteria for LVH or RVH, but overall, grossly normal with what's going on with these ST segment changes. And in this case, this is early repolarization. And I picked this EKG because the early repolarization is rather marked. And the reason why it's so marked in this EKG is because the T waves are big. And this is going to be one of the things you're going to probably wind up facing is because it's such a common finding. How do we identify whether or not something is a normal early repolarization versus maybe an ischemia pattern or an inflammation pattern? So there are a few things that you can use, and that EKG had a lot of these sorts of features. The first I like is this smiley face. These are both the same strip right over on the right side of the screen. So while the red is covering it up, there is this smiley face or this upslanting feature of the ST segment. The other thing you can sometimes see is this fishhook pattern. If you see that fishhook, that's a really good sign, but this is not always present. So if you don't see the fishhook, it doesn't necessarily mean that there's not early repolarization. But in the case where you have a pretty significant ST segment elevation and you're questioning, gosh, this looks too much to potentially to be early repolarization, I'm starting to get concerned, you can do what's called the ST to T wave ratio. And that's usually going to be less than 25%. So you can measure how tall or how many boxes you have going up for your ST segment and the total height of your T wave, and that should be under 25%. So if you've got, like in that prior one, a 16 millimeter T wave, you can have 3 to 4 millimeters of ST segment elevation. And that's why that looked so drastic on that prior EKG. Because the T waves were just rather large. There was nothing wrong with this particular patient. They just happen to have very tall T waves and rather marked early repolarization. Now, the other thing that can be helpful is where you're going to see the most early repolarization. Typically, it's V4, but can be seen through the precordial leads, 2, 3, 4, 5, sometimes even in 6. It's usually a lot less in leads 1, 2, leads V1, V2, and V6. I'll often also see it relatively easily in lead 2, the limb lead, but it can be seen oftentimes as a little bit of ST segment change in any of those leads. So now we have another EKG. And this one was read by the computer as sinus rhythm, atrial premature complex, repolarization abnormality suggests left ventricular hypertrophy. I'm going to go out and just tell you, EKG is wrong, and I am not quite sure what the EKG was seeing. Sometimes I can figure it out. Sometimes they're off in la-la land, and this is a la-la land EKG. I'll give you a few seconds to look at it. So this EKG is WPW. And we can see the pre-excitation in multiple leads. And so you can see it well by all of those arrows. I want to highlight this one down below lead V1, the rhythm strip. A lot of people don't see the pre-excitation when it's downward sloped pre-excitation. The pre-excitation is going to follow the direction of the QRS. So it seems to always be presented in textbooks as this upslanting pre-excited pathway, but it can be down as well. Here's another example. It can be a lot more subtle. I think this one down here probably shows it the best. Some of the clues that you're going to look for are going to be, here's another EKG, some of the clues you can look for are going to be that there's going to be a short PR interval and a wide QRS. So, and the wide QRS is going to have a different pattern than what we typically see with wide QRSs when we have, for example, a right bundle branch block or some sort of interventricular conduction delay. the QRS is going to be slurred towards the front of the QRS, and it will get sharper and narrow as the QRS progresses. But if you're seeing a short PR interval and a wide QRS, that's when your spider sense wants to go off and say, I need to look carefully to see, is there any evidence of WPW? I spent 3 years collecting EKGs with WPW before I finally had a computer say, this patient had WPW. I had multiple EKGs that said had WPW that did not. So I hate to break it to you, but the computer is not going to be your friend on this one. So I think if you can remember this short PR interval, wide QRS, let's look very carefully. That will help with your assessment on these patients. And if you can get good at looking at how those QRF morphologies look, that'll help you even further in distinguishing things like right bundle branch block or other kinds of interventricular conduction delays and this pre-excitation. Now, these are the EKGs that give most of the cardiologist palpitations, especially if we're not expecting to get this EKG. So these are going to be, I have 2 EKGs here, left ventricular strain and right ventricular strain. These are going to be things that we may see with like a hypertrophic cardiomyopathy, somebody with severe aortic valve stenosis, or on the right side, severe pulmonary hypertension, severe PS, other sorts of cardiomyopathies. We may see this sort of a thing. So a few things to point out. I think the most obvious one is over here in V6 is how tall that QRS is. It is giant. I think it was 30 millimeters. So massive voltage criteria. The other thing that I want to point out is the T waves versus the QRS. This should be a red flag for you. If the T waves and the QRSs, they want to face each other. They're kind of usually very close in axis. So they're going to have, if your T wave's upright, or if your QRS is upright, your T wave should be relatively closely upright. And there can be a little bit of variability there because they're usually not perfectly aligned. But if, like in this case, every upright QRS, we practically have a completely inverted T wave. None of them are facing each other. So if we're seeing completely inverted T waves, something unusual is going on here. Now, it could be that we just have a bunch of ventricular beats and we have lots of weird depolarization, lots of weird repolarization because they are all just PVCs. But in this case, we know we're not having that because this looks like sinus rhythm. So we're having a very abnormal EKG here. The other thing that's really important and part of this strain pattern are the ST segment changes. So we can see them really quite well over in V4 through V6. We'll see that ST segment depression there. In lead V1, we have a little bit of ST segment elevation. We have some milder ST segment changes in the limb leads as well. So these strain patterns are going to be voltage criteria, they're going to be ST segment changes, and then these T wave inversions. This is an example of a right ventricular strain pattern. So unlike the other one, we have much smaller voltages in V6, but we have actually a very large S wave. That meets voltage criteria. And then we can also see the same feature with the T waves. The T waves and the QRSs, for the most part, don't line up. And then when we look at the right side of the heart, we see bigger voltages. We see very dramatic ST segment depression in lead V2. And we have that really marked T wave inversion. So this is going to be right ventricular strain. Getting back to our case. Our patient had sinus bradycardia. Not very helpful. At least we don't have long QT syndrome or something like that, but didn't really increase or decrease our suspicion at all. So now what? Well, if we've got a normal exam and a normal EKG, the history is going to be where we have to rely. So how concerned were we with the history? Do we have things to suggest paroxysmal arrhythmia, other heart disease that maybe warrants further evaluation? Is this sounding like extrasystoles? Is this sounding like something that's relatively benign? So you have signs like a sudden onset, sudden resolution. Those are things that are going to increase our suspicion. Racing heart rate, those are going to increase our suspicion. Now, certainly if we've got an abnormal exam or an abnormal EKG, then I think we should be going over to cardiology for further evaluation. But the history is going to be where we're usually basing all of our choices. So, should you order a heart monitor at this point? I say maybe. I think if you've got good access to cardiology, a referral is perfectly reasonable. Depending on where your practice is and the social factors affecting the patient, maybe that's the best choice for you. So if they're going to have barriers, whether it's time, distance, other barriers to seeing cardiology, then maybe ordering a rhythm monitor is a reasonable choice. Now, I think having the right monitor is going to be an important decision. Really, I separate monitors into 2 to 3 different types. There's the old school Holter monitors, which were usually 24 to 48 hours, sometimes up to 3 days. There's event monitors, which look a lot like Holter monitors from what the patient experiences, but they usually are up to a month. They are fundamentally different, though, than a Holter monitor. A Holter monitor, everything gets recorded, from the first beat to the last beat. As long as they're wearing it, we have it recorded. An event monitor, however, only records events. So the patient has to say, I had this. Usually there's a button to push or something to activate on the monitor that says, this was it. A lot of the monitors will have software that are looking for funny things. So there is that little bit of backup should there have been an event that they maybe had when they were sleeping. It may pick that up, but we don't have a guarantee of that. Then we have these smaller monitors, the Zio monitors, BardyCam are the 2 that our group has been using. These can run for 3 days to 14 days. And these are much more similar to the Holter monitors in that they're recording everything, but they also will have a button or a way to activate to trigger, hey, I had an event, note this. And most of our group has moved over to just the Zios or BardyCam type monitors. From a patient experience, these are way better. I see less skin irritation, there's no wires, they feel like they can still do things. Swimmers, they're out of luck, I'm sorry. But most of the kids are still able to practice. They can still play. They can still run around. Some of them even still doing their sports if they haven't been restricted. I have had patients sweat them off, but I have had a lot of patients continue to do activity while wearing these monitors. So that's what I've moved to. If you are going to be ordering these, I always like to screen for kids who have really sensitive skin. And so if you have a kid that breaks out when you put a Band-Aid on, they can't wear a Band-Aid for 24 hours and they're breaking out, I usually try to pre-treat the skin. And if they've got access to Flonase at home, have them squirt Flonase on their skin. If they've got Benadryl lotion, you can add that as well. And that can really reduce the rear irritation. Some of them, if they've got to wear it for 14 days, they're still going to have some skin irritation and it may limit the duration of the monitor. But for a lot of them, that really improves the experience and can get you sometimes 5 to 7 days as opposed to 24 hours before they're taking it off. This is just like what the diabetics do for their skin care when they can't wear a CGM or their sites. Should you order an echo? If the exam's normal, it's going to be a very low yield test. And I think if you're ordering an echo, we want to ask really what the question is that we're trying to get. And a lot of times when we order an echo for the evaluation of palpitations, we're really trying to either, we've diagnosed an SVT and we're confirming that the anatomy is normal. So it's kind of an after the fact thing that we're often doing. or we're evaluating anatomy like coronary origins, which is very, very difficult. And a lot of times it is not adequately shown unless it's done by a lab that is doing a lot of pediatric echoes and doing them at a very high quality. So I would say oftentimes, especially for palpitations alone, one, it's probably not going to give you the answer that you want. And two, you may not even get the information that we want to get if we order it. So I'd be very hesitant to order an echo, especially outside of an acute care setting. If you're in an acute care setting, you feel like you need an echo because you want function or something like that, go for it, absolutely. But on an outpatient basis, it's probably not going to help you a lot and may have a lot of expense that's just unnecessary. All right, back to our case. So on my case, I ordered a rhythm monitor on him. We were able to get him to do pitching. He had an episode, we captured it, and I don't have a strip up here, but he had a sudden change in his heart rate, narrow complex tachycardia, rate of 224, and then the resolution was also sudden. Went from the tachycardia back to a sinus rhythm. He had SVT. I initially started him on a beta blocker, but he didn't like it. He was okay when he pitched. He was okay for most of the basketball game, but when it got really intense, he was like, I feel like I'm limited. So when it got full court and they're really going back and forth, he felt like he couldn't keep up as well as he used to. So we stopped the beta blocker when we sent him over to do an EP study with an ablation. And he had what's called AV nodal reentry tachycardia. That's when the AV node has the dual physiology, dual pathway of fast and a slow. And they did a ablation of one of those pathways, and he had resolution of his symptoms. The EP study for AV nodal reentry tachycardia usually has a success rate over 90%. Very, very successful. WPW is a little bit less than that, because a little bit of it depends on where those pathways are, and some people have multiple pathways, and that can be a little bit more challenging. But still, usually over 80%, 80 to 90%. So kind of going back to the question of, you get this patient, can I let them play sports? Well, it really comes down a lot to the history, the exam, and if you've got a normal EKG, then if you've got a benign sounding history where it's just skipped beats, maybe they have a forceful beat, but it's not fast. I will very frequently see patients who have ADHD who complain of palpitations only when they're laying in bed at night. I've so far not found anybody with that history who's had any sort of arrhythmia. And usually they're saying, I feel a forceful heartbeat. Maybe it's a little fast. That's usually a very benign history. If it's just a little bit fast, and I'll even ask them, is it just a little fast? Or is it like really, really fast? Then lower suspicion. We can probably let them play. Also, how they feel helps us understand whether or not we feel comfortable clearing them or not. If they're like, yeah, I keep doing what I'm doing, doesn't really keep me from doing stuff, we're probably at a very low risk of having a serious adverse event and may be reasonable to allow them to play. However, if we have a concerning history, certainly if we're having abnormal exams with a concerning history, or there's an abnormal EKG with a concerning history, then we should certainly consider restricting them. Some of those concerning history things are going to be when you're starting to combine multiple symptoms together. That palpitations with chest pain, palpitations with syncope. Exertional symptoms. Although, thinking about these exertional symptoms, one of the interesting things about this particular history that we got is with the highest heart rate, when he's playing full court basketball, he wasn't having symptoms. It was when he was pitching. And sometimes with arrhythmias, I think we often think about coronary artery type pathology and superimpose that kind of pathology where we have a fixed lesion, where we have ischemia beyond a certain amount of cardiac output or cardiac demand. The physiology and the pathology for arrhythmias is not the same. So we don't necessarily have those kinds of reproducible histories with arrhythmia. And I think for this case, even though it wasn't necessarily a catecholinergic-based tachycardia, the stress and adrenaline of pitching was what was setting him off. It was that stress of sport, which is probably also why he wasn't having this during practice and why he was a little less stressed. He wasn't the only person. He wasn't where the spotlight was in basketball, so he usually wasn't having it with it. Kind of again, this will be in your packet, just things to think about when to refer. If we're getting a little bit more detail on heart rates, so certainly too fast to count, as I've mentioned multiple times. If we're getting heart rates that are unexplained and over 180, then I start to get a lot more concerned. So if we're running around, then we know we can calculate or estimate what the predicted heart rate is. A lot of younger kids, they don't have much of an aerobic capacity, so they shoot their heart rates up super duper fast. They go in an anaerobic zone, they get their heart rates to 160, 180 very, very fast. So with activity, we can get their heart rates up pretty quickly, but if we're sitting around, we have a heart rate 180 or higher, I'm really starting to be suspicious. 150 is kind of a cutoff that I often will give families, because one, they should usually be able to count for something less than 150, and the chances of it being an SVT under 150 or any sort of significant arrhythmia is exceptionally low. So that's kind of my low cutoff. I feel like I'm probably not going to miss anybody if I use that cutoff. And so I like the 150 cutoff, but certainly the higher that number, the more concerning it is, especially if we don't have some sort of physiology to explain a higher heart rate. Go back. And I'm going to also point out, if the family wants a second opinion, I'm happy to talk with them, and I think most of my colleagues are as well. We know we're here to support you, and we can certainly see these patients even if your suspicion's pretty low. All right. So, and again, kind of a summary, some of the history findings that may help you kind of form your differential diagnosis. And then again, I want to drive home that point of anxiety. I really, really recommend not using anxiety as something that's going to raise or decrease your suspicion, because we really don't know whether or not the anxiety is appropriate or inappropriate. And I'll talk to families about that, especially if there is sometimes the families are trying to minimize symptoms, saying this is probably just anxiety. And I'm like, I don't know. I want to hear your story. And I think that's the important thing. Don't use anxiety, because if you're an SVT and you're not anxious, I'm kind of surprised. That's why I'm like, don't use anxiety. All right? Any questions? Yes?
For the concerning history, does that also include family history?
So a lot of the history that I was focused on was the personal history, but certainly if we're getting some of those family history elements for inheritable arrhythmias, that really increases the suspicion. Most SVT, which is going to be the most common type of arrhythmia, is not going to have a strong family history. That being said, I have had 2 or 3 families where, like, there's probably something genetic going on here, because we've got now 3 or 4 people that have had WPW or some sort of SVT. Dad with AFib, not that exciting. Yes?
On this kid, once you got the history and just the behavior side is great, but had the sudden symptoms, would you restrict his play so that he got?
I was able to get a monitor on him pretty quickly, so I didn't, because I wanted to reproduce the symptoms. And he was tolerating things really well. So I think it would have been reasonable. I did not in his case, but that was because I didn't think I was going to get it any other way. I used to do a lot of exercise tests, but they were so often negative that I felt like I was getting a lot of false negatives. So, and this story actually is one of the things that really kind of drove in the nail in the coffin of the exercise stress test, because I was like, why do I think I'm going to get a positive stress test? If he can play full court basketball, get his heart rate up to max, be at the peak of his competition and not have symptoms, but he's having it on a pitching mound. So this actually changed my practice. So I like getting things in situ. So if I can, that's, I think, the most likely way we're going to find these things is to do the testing. And like in this case, I thought I needed to let him play so that I could actually get an answer. I think that's not unreasonable in this particular case. But it is, I think the guidelines would say to restrict. But how likely they are to have a sudden cardiac arrest, this story, I think, very, very low. Because he had a very clear history that he's not having any sort of extremis.
And I would just add that we're always happy to take those calls from you guys too. If you have a patient, you're like, I don't know if you need to restrict or not, we're happy to take those calls. We find ourselves, I would say, unrestricting much more than restricting, of course, and that's what we're here for. So if you guys have questions, you're welcome to call us.
Our practice is different though, so.
Yeah, that's true. Good, yeah, I can bring the microphone around too for you guys. So.
Oh, goody. Thank you. Are there symptoms of like long QT syndrome? I only ask because sometimes, we all have new fancy EMRs, and sometimes they do, like if you have somebody on 2 different medications, they'll say there's a risk of prolonging the QT. And I never know what to do with that. Like usually I'll just change the medication because I'm scared. But is there, I don't know anything about long QT, and maybe that's not the place for you to talk about it, but if there's anything, I'd appreciate it.
Yeah, so long QT, if it's just simply a prolonged QT, you're not going to have symptoms unless you have an arrhythmia because of the long QT. In fact, I'm going to show you another EKG. I have an EKG up here, but you can have obviously the classic ventricular tachycardia, but you could also have this. Now, this was on a 6-month-old, and this baby had long QT syndrome. So you could have bradycardia because the sinus beat is hanging out right on top of the T wave. And the AV node's refractory because we're still only halfway through ventricular repolarization. So you could have bradycardia as a result of long QT, or you could have your classic ventricular arrhythmias associated with it. But if you just have a prolonged QT interval, I would not expect symptoms.
I think one last comment I would add that popped in my head is you were talking, James, and that question, I'm not exactly answering your question, but I find myself in the clinic lots of times not knowing if a patient has SVT or not, but they've had palpitations and we're trying to decide about a monitor. I imagine you all encounter that as well, and we're always happy to see patients for any palpitations, but I know parents are worried, right? They're worried about the heart. So one little tidbit that might be helpful that I use in my clinic is if we have an EKG that is normal, there's no WPW and there's no long QT, and they've never fainted, I tell parents all the time, well, I don't know for sure if there's an arrhythmia or not, but I can say pretty confidently there's no evidence of anything dangerous going on here. If we've never fainted and the baseline EKG doesn't show any of these more rare genetic or WPW findings, we can say pretty confidently there's nothing dangerous. And so it kind of takes the pressure off a little bit, and we can decide to do a monitor or do one later, So anyway, if that's helpful, that's something that I use in my own practice. So. Any last questions? We got 1 minute, but if that's it, we're going to move on to the next talk. Thank you very much. Wait, one last question. Yeah, right here. One last question. Let me bring the mic over.
I know you spoke to stimulants a little bit, but I feel like I'm finding more and more having like teenagers who have palpitation symptoms when they're awake or when they're active. And so I'm curious your threshold then for like EKG versus pausing and switching.
I think starting with an EKG is, my threshold is the floor, pretty much. If you thought about an EKG, it's probably reasonable to get it. It's such an inexpensive test, and it can help you with your suspicion. we could have probably a very long conversation about ADHD medications, and I've seen all sorts of things that I cannot explain with them. Sometimes just stopping them and restarting them has fixed the problem. Sometimes switching over to a different medication, even though they've been on this medication and that dose for 5 years, and now they're like, they went from 8 to 15 or 8 to 12 or something like that, and now they're all of a sudden having tachycardia at rest. Sometimes switching over to a different medication that has pretty much the same mechanism of action, just a different release system works. I cannot explain why some patients have problems with ADHD medicines or not. And there can be room to tweak, to play, to change, to pause, to do things like that. But I think when it comes to getting an EKG, I think it's a very, very low yield test. If you've got a normal EKG, then you can at least feel like, so far I'm not seeing anything that says, maybe I don't have time, maybe I should definitely stop, maybe I should make a referral. That maybe gives you a little bit of room to say, I'm going to try to manage this on my own, if you feel comfortable doing that.
Let's give James one more round of applause. Thank you, James. That's awesome.